Okay, hello guys. Good evening, everyone. Welcome to one more Prof Exam Made Easy session, and this time we'll be starting with anti-diabetic drugs. See, as per anti-diabetic drugs is concerned, I hope I'm audible and everything is clear. If everything is okay, we can proceed up further. So, as per anti-diabetic drugs is concerned, as usual, we'll be keeping it as crisp as possible. Within 20 minutes, I'm going to be explaining to you a diagram. And if you could just draw this diagram in your exams, that is going to be fetching up more than 80% of the marks. Because this is going to be an universal diagram which can be used for all of the different anti-diabetic drugs mechanism of action. Of course, theory you can have it. You can learn it at any different points of time from the UG curriculum app, and also we have lots of notes to be there. But as for the exams is concerned, we need a proper diagram there, and that's what I'm going to be giving up to you. Please make sure that you use this diagram in your exams in the first page of the long answer made for anti-diabetic drugs. um, okay, so we'll start with that. First of all, we have to know about how actually the insulin is getting synthesized and how it is going to get released out. We'll start with the first step. Consider this is where your beta cells of pancreas is. This is what your beta cells of pancreas. Inside the beta cells of pancreas, we have a vesicle which contains insulin in it. Inside the beta cells of pancreas, we have vesicles which contains insulin in it. And here is where your blood vessel is. We have the blood vessel which contains the blood sugar, whatever it is going to be absorbed from the intestines. And here is where your intestines are. We have intestines situated here. The intestines is made up of a lot of epithelial cells. We have intestinal epithelial cells situated here. Out of all the epithelial cells, one cell will be extremely longer, and that cell will be called as L cell. We have two cells which is important clinically. The first one is L cell, the other one is K cell. L cells and K cells, as simple as that. So now this L cell and just give me a minute. Okay, I think everything is good. So we'll proceed on further. We have two different cells, L cell and K cells. And where were we? Any food which all you take, be it any complex carbohydrates. Hi, Hemant, Akshar, good evening. Hi. So any food which all you take, be it going to be a complex carbohydrate or any types of carbohydrates, it is going to be coming up inside the intestines, but these are going to be there in polysaccharide forms. Please note down, polysaccharide forms are not going to be absorbable. It cannot cross this membrane. Well, that's why polysaccharides needs to be broken down to monosaccharides. Polysaccharides needs to be broken down to monosaccharides. Again, if a multiple complex carbohydrate is getting broken down to small molecules, the enzyme which is involved over here would be named as, if proteins are getting broken down, that is called as protease enzymes. And if carbohydrates or glucose is getting broken down, it's going to be glucosidase enzymes. It is going to be glucosidase enzymes. We have alpha and beta glucosidase, but just first of all, just know that it is a glucosidase enzyme. This glucosidase is responsible for breakdown of polysaccharides to monosaccharides so that these monosaccharides can get absorbed from the intestines into the blood. It will get absorbed from the intestines into the blood. So we have glucose, which has gained entry into the blood. Good. Now this absorption is going to be happening, but before that, when these monosaccharides comes into contact with the K cells or even the L cells, whenever these monosaccharides comes into contact with the K cell and L cell, there will be secretion of certain substances. From the K cell, there will be release of a molecule called as GIP. And from the L cell, there will be release of a molecule known as GLP. So GIP and GLP. GLP stands for glucagon-like peptide, whereas GIP stands for glucose-dependent insulinotropic polypeptide. GIP and GLP. Okay, GIP and GLP. GIP stands for glucose-dependent insulinotropic polypeptide. GLP stands for glucagon-like peptide. These two molecules are peptide molecules. It is not going to be a long-lasting one. It is going to be having a shorter duration of action. As all we know, any peptide or any ester molecule will be having a shorter duration of action. Similarly, here peptide molecule is there. That is also going to be a shorter acting. Why? Because peptide molecules are quickly getting broken down by peptidase enzyme, whereas ester molecules are quickly getting broken down by esterase enzymes. These peptidase and esterase enzymes are powerful enzymes, guys, which can easily break down any of the peptides or esters. That's the reason why these molecules are always having a shorter duration of action. So be it GIP or be it GLP, this molecules is going to be binding up with its own receptor on the surface of the beta cells of pancreas. Here we have a receptor. 1, 2, 3, 4, 5, 6, 7, which is a G protein coupled receptor. As we all know, G protein coupled receptor are 7-pass transmembrane receptor, which passes through the membrane 7 times. This G protein coupled receptor, here it is going to be GS coupled. So what is the take home point? If it is a GS coupled receptor, it is going to be stimulating, this will be stimulating adenylyl cyclase. Whenever adenylyl cyclase is getting stimulated, that will increase intracellular cyclic AMP, which in turn is responsible for the release of insulin. As simple as that. So simply, whenever there is a food which you have taken in, it gains entry into the intestines, and when it is getting exposed off to K cells and L cells, there will be release of GIP and GLP-1, which in turn will bind with GS receptors, raising the intracellular cyclic AMP, which is the second messenger, by the way, thereby increases the insulin release. Even if you couldn't understand second messengers or any of the other concepts, don't worry, because we have a separate session to explain about what exactly is a G protein coupled receptor. Just note down these points. This diagram would be enough in your exams. When you draw this diagram and draw only one particular, for example, if the question is regarding what is the mechanism of action of anti-diabetic drugs, and explain something about sulfonylurea, you just need to draw this diagram and mark that particular area to tell that this is the mechanism of action of sulfonylurea. That's it. The whole mark is going to be there with you. Now, we'll proceed on further. So now whenever this monosaccharides or drugs or the food which comes into intestines is stimulating that, the second molecule, what about those glucose which has gained entry into the blood? How it is going to be stimulating the insulin release? These glucose molecules which are there inside the blood, the only area of entrance is not food, my dears. It is also produced because of gluconeogenesis, which is happening in the liver. So we have liver here. We have liver. From liver, there will be synthesis of glucose, which again will be secreted out into the blood with the help of gluconeogenesis. Gluconeogenesis. Good. Now all this glucose is getting stored up inside the blood. How it is going to be stimulating the release of insulin? First of all, this glucose molecule will be gaining entry into the beta cells of pancreas. Glucose molecules will gain entry into the beta cells of pancreas with the help of a particular transporter. This transporter is named as GLUT molecules. Is it going to be GLUT2 or GLUT4? It is GLUT2 molecules. Just remember that GLUT4 is there in muscles. Remember this, GLUT4 is there in muscles. GLUT2 is there in the pancreas. GLUT2 is there in the pancreas. 4 is there in the muscles. 2 is there in the pancreas. That's how we easily remember it. So GLUT2 is going to be there in the beta cells of pancreas. So thereby glucose molecules is going to be, GLUT means glucose transporters. Glucose will be taken up into the beta cells of pancreas. Glucose in turn will be producing ATP molecules. But before that, we have a specific transporter situated here, and the function of that transporter, we have a transporter situated here, and the function of this transporter is to produce efflux of potassium. Normally, this is responsible for efflux of potassium. But whenever the ATP levels rises up inside the cells, whenever ATP rises up inside the cells, this will produce blockade of this potassium channels. When ATP level rises and it is producing blockade of potassium channels, potassium efflux, what will happen to the potassium, my dears? Potassium will be accumulated more inside the cells. There will be more accumulation of potassium. Whenever a positive charge is getting accumulated inside the cell, just tell me the answer. What would be the final mechanism? It's going to be producing what? Depolarization or hyperpolarization? It's going to be producing depolarization. Hi, Achan Khan. Hi, good evening. Sorry for that. Sorry, I missed your message. Okay. So this potassium, whenever it is getting accumulated inside the cell, will be producing depolarization. Of course, we know whenever there is depolarization, there will be influx of calcium. Calcium will gain entry only if a cell is depolarized. We have explained that multiple times in all of our sessions. So when calcium gains entry into the beta cells of pancreas, this in turn is responsible for exocytosis of the contents of the vesicles. What is the content of the vesicle? Insulin. So we have two different mechanisms of how the insulin is getting released out. A small recap, my dears. First step, the food molecules which all you have taken will gain entry into the intestines. It is going to be there in polysaccharide forms, which cannot be absorbed, so it has to be converted to monosaccharide forms. This conversion will happen with the help of glucosidase enzymes. Monosaccharides can be easily absorbed back into the blood vessels. Now, when these monosaccharides comes into contact with the K cells and L cells, from the K cells, there will be release of GIP, glucose-dependent insulinotropic polypeptide, and GLP, which is glucagon-like peptide. When these molecules are binding up with its own receptor, which is a GS-coupled receptor, thereby intracellularly acetylcholine will be increased, cyclic AMP will be increased, which in turn will stimulate the release of insulin. The first step of how insulin is getting released by the stimulus which is happening from the intestines itself. Step number 2, what about those glucose? Those glucose which has gained entry into the blood either by the intestine or by absorption from the intestine or from the liver itself. With the help of gluconeogenesis, certain glucose will be synthesized, it will be released into the blood. Now, these glucose molecules will gain entry into the beta cells of pancreas with the help of GLUT2 molecules. I hope you remember that 4 is there in muscles, 2 is there in the pancreas. Now, this glucose in turn will be producing ATP molecules. Whenever there is rise in the ATP, there will be blockade of a potassium efflux. So potassium is not getting let out. Potassium will be accumulated more. A positive charge is getting accumulated, which in turn will produce depolarization. And we know a formula, which means calcium will gain entry only if a cell is depolarized. Now, whenever there is depolarization, there will be influx of calcium, which in turn will stimulate the release of insulin. Two different mechanisms, my dears. Now, this potassium channel which we have written over here, we have a specific name for it. Simply one, it is a potassium channel, but it is sensitive to increased or raised ATP inside the cell. That's why it is also named as ATP sensitive potassium channels. That's why it is also named as ATP sensitive potassium channels. We have other name for it. We'll discuss that later. Good. Now, we'll move to the next part. The next part is how this particular insulin which is getting released up is going to be utilized by the peripheral muscles. Be it the skeletal muscles or be it the adipocytes, how it is going to be utilized. First of all, consider here is where your peripheral cell, it's going to be any cell, be it like skeletal muscle or adipocytes or any cell, it's going to be there inside the body. Now, inside those, nearby we have the blood vessel, guys. Nearby we have blood vessel. Now, inside the blood vessel, we have the insulin which is released. Insulin which is released is going to be there inside the blood vessel. Now, what happens is this insulin which is released will come and bind with its own receptor which is there on the surface of every individual cell, which is named as insulin receptor, as simple as that. Insulin receptor. Now, what is the function of this insulin receptor? Whenever a cell is expressing out an insulin receptor, it means it needs glucose molecules. That's the concept behind it. Insulin receptors intracellularly are bounded with tyrosine kinase molecules. What's the function of tyrosine kinase, which is again an enzyme which is present intracellularly? An impulse will land up inside the nucleus of this particular cell. We have the nucleus. The impulse will gain entry into the nucleus. This nucleus will be stimulated, transcription, translation, protein synthesis will happen, and because of this, there will be synthesis of GLUT4 molecules. There will be synthesis of GLUT4 molecules. So insulin receptors are the reason for the synthesis of GLUT4 molecules. Now, what's the next step, my dears? What's the function of GLUT4 to transport glucose molecules? So these glucose which are present inside the blood, glucose molecules which are present inside the blood will be taken up into those cells. Will be taken up into those cells because of this GLUT4 molecules. Is that clear? So simply a small recap again, insulin is getting released out from the beta cells of pancreas, which will bind with the insulin receptor, which intracellularly has got activation due to tyrosine kinase. That in turn will gain entry into the nucleus, transcription, translation, protein synthesis, GLUT4 molecules will be synthesized. This is what insulin receptor is. When insulin comes and binds with it, GLUT4 molecules will be expressed out. Via this GLUT4, glucose will gain entry into those cells. After the glucose is gaining entry, GLUT4 molecules, or to simply the insulin receptors, will be internalized. Thereby the GLUT4 molecules also will be internalized. Whenever glucose is necessary, insulin receptor will be expressed out, GLUT4 will be expressed out. Whenever it's not necessary, insulin receptors will go back, GLUT4 molecules will go back. Good. This is how peripherally it is going to be utilized. Now, how this glucose molecules is getting excreted out from the body, we're going to be talking about that too. Again, consider here is where your glomerulus is. We have glomerulus and we have the proximal convoluted tubules. We have the proximal convoluted tubule and the descending limb of Henle's loop. Here we have blood vessels, my dears. Here is where your blood vessels. Now what happens is glucose molecules, whatever be that, be it the glucose which is synthesized from the liver due to gluconeogenesis, or the glucose molecules which is absorbed from the intestine, whatever it's going to be, these glucose molecules will gain entry into the proximal convoluted tubule. Glucose molecules which is there in the proximal convoluted tubule will not be, actually it is secreted, actually it is moving into the PCT to get excreted out. But unfortunately, most of the glucose molecules will be reabsorbed back into the blood. Most of the glucose molecules will be reabsorbed back into the blood with the help of a specific transporter situated here, and that is named as sodium glucose transporter, that is called as SGLT2 molecules. With the help of this SGLT2, most of the glucose will be reabsorbed. Imagine a patient with the diabetes mellitus. What exactly is happening? There is too much sugar which is accumulated there in the blood, which is further been worsened because of the action of SGLT2, sodium glucose transporter type 2. These are the different targets which we have currently, my dears. These are the different targets. Hi, Karthik. Hi, Ravi. Hi, Chandu. Good evening. Good evening. Thank you so much. Okay. Okay, so glucose molecules which is gaining entry into the urine, it is going to get reabsorbed back inside the blood vessels. Thereby, the glucose is gaining entry into the blood, it is remaining inside the blood, and it is rising up the blood sugar levels. These are the different targets which we have as per anti-diabetic drugs is concerned. We'll start from the first one. Let's start from the top. What are the different drugs which we have and what are the different mechanisms of actions of individual drug? The first one, the drug which is inhibiting this ATP sensitive potassium channels are nothing but sulfonylureas. Sulfonylurea and meglitinides. Sulfonylurea and meglitinides, two drugs which tend to inhibit this ATP sensitive potassium channels. Sulfonylureas are nothing but your glimepiride, gliclazide, tolbutamide, all the drugs. Meglitinides, we have repaglinide, naticlinide. So when you come across any question based on sulfonylurea or meglitinides, you just need to draw this particular diagram, guys. You just need to draw this diagram alone. I'm going to, as I've told, I'm going to be drawing up a diagram and I'm going to be giving you which diagram has to be drawn in your main exams, be it any question based on individual topic. Sulfonylurea or meglitinides, this marked up area is the diagram which you have to draw. Now, the second drug is going to be a drug which is going to be inhibiting this gluconeogenesis, and that is being done by metformin. I hope you know about metformin, my dears, which is biguanides. We used to call them as biguanides. Again, if you come across a question regarding metformin as a long answer or even a short note, this whole diagram has to be drawn. Simple as that. This diagram has to be drawn, and that is enough for your metformin, guys. Moving on to the next one, we have some drugs which might be stimulating this GLP-1. GLP-1 might be stimulated because GLP-1 usually will increase the insulin release. What if I design a drug in such a way that it is going to be increasing the GLP-1 levels? Those drugs are named as GLP-1 analog agents. GLP-1 analog agents. Example, we have exenatide. Example, we have exenatide. Okay, so when you come across a question regarding GLP-1 analog agents, again, what you have to draw, this is the only thing which you have to draw, my dears. This whole part is the one which you have to draw for GLP-1 analogs like exenatide. The second one, see, as I've told, these are peptide molecules, right? GIP or GLP, be it, it's going to be P stands for peptide molecules, which means it's going to be quickly broken down by a peptidase enzyme, which we explained about again before itself. And the peptidase enzyme, which is responsible for the breakdown of GIP and GLP-1, is named as DPP4, dipeptidyl peptidase type 4. This is the enzyme which is responsible for breakdown of both of these peptide molecules, DPP4, dipeptidyl peptidase enzymes. This dipeptidyl peptidase enzymes will be inhibited by certain drugs. This will be inhibited by certain drugs. So what will happen if you inhibit DPP4, GLP-1, GIP will be increased, which in turn will increase the insulin release. And these drugs are what we call as gliptin agents, DPP4 inhibitors. DPP4 inhibitors like gliptins, sitagliptin, vildagliptin, teneligliptin, all the gliptin agents. The next one, we have drugs which might inhibit this glucosidase enzymes, alpha glucosidase. What will happen if you inhibit this glucosidase? Polysaccharides will remain as polysaccharides. Absorption itself will be prevented. These drugs are sugar or cholesterol, carbohydrate absorption inhibitors. Glucosidase will be inhibited by acarbose, voglibose, and miglitol. I'm going to be writing up only two drugs over here because I'm not here to write about the classification. It's not going to be useful for you. So acarbose and voglibose will be inhibiting glucosidase. Thereby, it will prevent the conversion of polysaccharides to monosaccharides. Simply, it is a carbohydrate absorption inhibitor. Moving on to the next one, guys. What about this? Do we have some drugs which might increase the synthesis of insulin receptors? This insulin receptor will be stimulated by thiazolidinediones. Thiazolidinediones, example, pioglitazone. Glitazone agents, my dears. Thiazolidinediones, example, pioglitazone, whereas these drugs will be stimulating the insulin receptor synthesis. More insulin sensitivity in the periphery, thereby more glucose entry into the cell will constantly be happening there. We'll move on to the last drug, which is the most important one, and that is the newer one, is SGLT2 inhibitor. We have some drugs which might inhibit the SGLT2. These drugs includes gliflozin agents. These drugs are gliflozin agents. Please note down, any drug, if it is having GLI in its name, it is a glucose inhibitor agent used for diabetes mellitus. That's how we can easily remember it. GLI means glucose inhibitor, which is used for diabetes mellitus. So when you come across gliflozin, of course, you're going to be landing up in this question for the exams because it's a very important question. Recently, it has been proven to be very much highly effective for most of the patients for whom we can't even control the blood sugar, even with insulin as monotherapy too. So in those cases, we are adding up gliflozins. Dapagliflozin are commonly used one in practice. When you come across a question regarding gliflozin, you just need to draw this diagram and that's it. The other points which all you have learned from your theory would be more than enough. Then here, whenever you come across a question regarding thiazolidinediones or pioglitazone, this would be more than enough. Again, acarbose or voglibose, this diagram would be enough. Gliptins, you have to draw this diagram, which all we have from here till the beta cells of pancreas, you have to draw. GLP-1 analogs, you have to draw. We have already explained what are the things which you have to draw. Similarly for metformin, sulfonylurea, and meglitinides. With this, we have completed this particular session, buddy. I hope. Hi, Tinu. Good evening. Hi, Tinu. Good evening. Sorry, I just missed your message again. With this, we have finalized this session. Whenever you come across a question regarding diabetes mellitus, I request you to draw this diagram as per needed. Good. Thank you so much. We'll meet up in one more Prof Exam Made Easy session. Bye-bye. Good night.